afternoon. I'm Jacob O'Connor. I'm a graduate student at the University of Washington, part of the University of Washington's Engage program, and I'd like to welcome you to the event tonight. I do research in the Baker Lab, trying to design small, tiny little proteins that will eventually be used to make new types of drugs. And I get to have this opportunity because of the special collaboration between Town Hall, the UW Engage program, and this year, it's Technical Books. Together, they host a series called UW Science Now as part of the Seattle Science Lectures. Sponsors include Microsoft, Boeing, and the Bill and Melinda Gates Foundation. Tonight, each speaker's program will run for about 25 minutes, including 5 minutes for your questions. There will be a 5-minute intermission between talks so that you may purchase a drink at the bar or use one of the gender-neutral restrooms right over here. Before I introduce our first guest, though, I'd like to mention the next event from our science series. The next night of talks in the UW Science Now speaker series will be right here, again, on May 26th, starting at 7:50. Leah Isquith-Dicker will tell us about social networks and hunger in Peruvian communities. Hallie Stone will discuss phytoplankton and coastal upwell. And Hitsue Cavalier-Solis will speak about tree frogs. Now for our first guest. Addiction to opioid pain pills can have devastating effects on lives and families. But these drugs can also change lives for the better by providing relief for patients with chronic pain. Our next speaker will tell us about the development of better, safer pain medications to reduce their addiction risk while preserving their ability to relieve pain. Please give a warm welcome to Katie Reichard.
And the thing is that in my family, I have multiple family members that if you looked into the medicine cabinet, you would maybe start to see some red flags. Maybe you would see a bottle of Vicodin, or you would see hydrocodone, Percocet, Dilaudid. If you recognize the names of these drugs, it's because they're prescription opioids. They're often prescribed for pain, but in the news lately, you've probably heard them in association with addiction, with overdose. And you would maybe start to make some assumptions. That's okay. In the case of my family members, you would see these medications because they're part of every 3 in 20 Americans who experience chronic pain. Chronic pain can happen to people for a variety of reasons, for back pain, joint pain. Many women experience reproductive organ pain, like polycystic ovarian syndrome and endometriosis, which is often overlooked and misdiagnosed in women. And all of these causes of pain are incredibly intrusive and incredibly costly. So in the United States, when compared to other common public health problems like diabetes and substance use disorder, we actually see that the cost of chronic pain compared to $330 billion and $442 billion is $200 billion higher than all substance use disorders. So this is alcohol use and illicit drug use combined, and nearly twice that of diabetes. And these are costs in lost wages, disability, healthcare, and cost to GDP. But pain is a lot more than economic. It's deeply personal. So I'm going to give you some quotes from actual pain patients. Because if you haven't experienced it yourself, it's hard to imagine what having intrusive pain will be like on a daily basis. Your body feels like concrete. On my best days, it's an unyielding sense of discomfort. It's a good day if I can lift my arms. I'm engulfed in a thick, disorienting fog, and it's like I have fire ants arguing in my joints. I said that word intrusive, and pain is designed to be intrusive. It keeps us safe. It's evolutionarily advantageous for us not to move around if we're injured or hurt. But when it's happening on a daily basis, relief is needed for us to have relationships, go to our jobs, and the many things that many of us who don't have pain take for granted on a daily basis. So many chronic pain patients rely on prescription opioids. And you may have read in the news lately that opioids aren't effective for chronic pain. While there's also many studies that indicate for some subpopulations they are effective. And so it's important to recognize that for our patient populations, we need to recognize their needs and treat pain when it's able to improve someone's quality of life. Opioids act on neurons, and that's where I get it. I'm a neuropharmacologist, and I study how small molecules act in the body. And neurons are cells, just like red blood cells travel throughout the body, pumped by the heart to deliver oxygen. And muscles are small cells that act in concert to move our limbs and our fingers. Neurons are specialized cells within the brain that send messages from our brain through our spinal cord filled with neurons in our vertebral column, and neurons reach out to our body to tell our muscles to move and also to receive information from the skin. In fact, if you look closely, you can see small little stringy neurons attaching to those muscles because neurons are what tell muscles to move. So how do neurons transmit pain to your brain? Well, let's imagine that you're walking and you step on a nail. Whew, that hurt, right? Well, how does the information get from your foot to your brain? So in your foot, there's a neuron, which is a small cell, and it has a long fiber that's reaching down to your toe. And when it receives information, it actually travels all the way up into your spinal cord, and there it meets another neuron. This neuron sends information to your brain, where it's able to communicate consciousness of pain. So zooming in, inside of your spinal cord, this neuron that signals pain releases signal onto the adjacent neuron. And when it releases that signal, the next neuron is turned on, which then transmits the message of pain until you have that consciousness. And you say, ouch, right? We've all experienced something like this, sometimes on a daily basis if you're clumsy like me. But when you take an opioid, what happens? Well, you take the pill, it travels throughout your body, and it actually acts on individual neurons that come up into the spinal cord, and so they release less pain signal, which in turn means that the second neuron that sends a message to your brain sends a much smaller message. And in turn, instead of saying, ouch, you might notice it, but it's not as intrusive, right? So if we reduce the level of intrusiveness of this pain, we can improve quality of life. So here's the problem. Opioids don't just act on pain neurons in the spinal cord. They also act on a different type of neuron. So that's where we get to reward. We all have a reward system, and it's designed, again, to keep us alive. Because if we're really hungry, we're walking along, and we find a stash of donuts, we don't know when our next food is going to be. We need to know, one, I got to stop and eat all of these donuts. Two, I need to remember that these donuts were here, so that next time I'm hungry, I can come back to this spot and eat the donuts. This is similar for things like mating and remembering, for sexually reproductive behavior that's rewarding as well. However, if everywhere you walk, everything is rewarding, you'll never know where to go back, and you won't know when to stop and engage in a rewarding activity. So at rest, there's a heavy brake on your reward system. And so until you encounter a reward, you're not filled with that euphoric, rewarding sensation. However, when you take an opioid, that brake on the reward system is released. In the same way that the opioid blocks the pain signal, it blocks the brake, which means that what's normally a non-existent or small reward signal is actually increased. And so instead of responding to donuts, all of a sudden just taking a pill can make you feel like you found a reward, and you begin to seek drug movements. What we find is that actually only about 2 in every 10 people who are prescribed opioids misuse them, and then from that population, about half of them go on to develop opioid use disorder, so only 10% of the entire population. At first you're like, okay, 10%, that's a fairly high risk, but it seems not that high, but then you start to think about consequences. And addiction is incredibly problematic in the sense that it can invade personal relationships, cause economic hardship, and many other problems, but most of all, it causes people to die. Opioid use disorder and opioid overdose have killed about 115 Americans every year in the last few years. 64,000 people died in 2016, and the preliminary data indicate that that number went up in 2017. So this isn't a small risk to take. And that means that if you're a doctor and a patient comes to you with pain, and you want to help your patient, and they tell you, I've taken opioids before and they help me, you have to make the best objective decision that you can. But if this patient needs this medication, or if you're putting more high-risk, potentially deadly drugs into the environment. So again, physicians are weighing risks. They have to look for an objective scale. So what's the scale? Who's seen this? Who thinks they know what a 10 is? No, it's not objective. None of us can tell within ourselves, and on day 1 in our lives, 10 is different than day 10,000, and we don't know when we'll reach our limit of what pain is. This is incredibly subjective, and when we get to subjective decision making, bias enters the picture. So now you have a confused, in pain, and biased patient interfacing with a physician who, although completely well educated in the medical system, holds just the same unconscious and sometimes conscious biases that we all do as Americans. And so what we see is that there are prescribing biases which affect already marginalized populations. Black Americans are prescribed opioids at 30 to 50% a rate lower than white Americans reporting the same pain. And again, if you walk into the ER and you're a man, or you walk into the ER as a woman and you report pain, you have to wait 15 extra minutes to get prescribed pain medication. And you're more likely as a woman to be prescribed antidepressants for pain. And when you think about that, think about how Black women fare when they report pain. If you haven't, look up the New York Times recent piece on Black women in pregnancy, and also watch the documentary about Serena Williams to see how these two converging identities affect how Black women are seen by physicians and how their pain is interpreted. And so again, these are unveiling the fact that as we have a higher risk decision, bias plays into it more. So the question is, can we make better pain medication? Can this reduce prescribing bias? And then if so, is this going to reduce harm? That's where I step in as a neuropharmacologist, because I think the answer may be yes. But there's a few things we need to understand about how opioids work. We've already talked about how they affect the neurons. Now let's look at an individual neuron and talk about the molecular signaling and how we might be able to take advantage of it in order to create opioids with less risk. So when someone takes an opioid drug, as we know, it causes pain relief, it causes euphoria or feeling high, and then finally it can cause overdose death because of reduced breathing rate. Overdose death is caused because of respiratory depression, and opioids reduce the rate of breathing. So when we look at the actions of an individual opioid, it acts on something called a receptor. So this is a molecule that straddles the inside and the outside of the cell. Outside of the cell, this opioid receptor interfaces with the molecules that are moving through the bloodstream, passing by the cells, and if you've taken a drug, it can find its matching receptor and bind to it. And then in the inside of the cell, the other part of the receptor transmits a message, which changes the activity of that neuron and in turn eventually produces behavioral responses like relief to pain and addiction. And so this change in the receptor activates several molecular processes. And through work from labs like my own, we found that one of these molecular pathways is what generates pain relief. And the molecular signals that produce pain relief are unique from the molecular signals which produce reduced breathing. And so if we could figure out a way to take advantage of this unique property of the receptor, perhaps we could create pain-relieving drugs that don't cause respiratory depression and overdose death. So, so if you were to imagine you're in a room and there's a lamp at a vanity, there's a lamp by your bedside table, and there's an overhead lamp. At night when you want to read, you just want the bedside table lamp. If you're doing your makeup and your partner's sleeping, you might just want the vanity. But the problem is there's only one light switch. And when you turn it on, every light goes on. You don't have another option. Well, the property we want to design drugs to have is finding a way to flip the light switch at just one, maybe 45 degrees, and all of a sudden just the vanity's on, or at 75 degrees and you just have the bedside table. So there are potentially drugs that when they bind to the opioid receptor, they cause a change in the side of the receptor that interacts with the molecules that cause pain relief, but not with the molecules that cause overdose death. So have we found these molecules, you ask? Well, interestingly, there are several compounds that drug developers have made and labs like my own have tested in cells. And there's one, olaceridine, which is currently in phase 3 clinical trials. So it's gone through its safety trials and it's moving on to look if it actually treats pain without the same problems in hopes to eventually be FDA approved. And it's been found that it blocks pain better than morphine. So you need to take less drug, which means that there's less side effects. Additionally, there's less respiratory depression. So for the same amount of pain relief, you have about half as much reduced breathing rate, which reduces overdose death risk. And conveniently, there's also less constipation and nausea. So these are also really, they're sometimes seen as small side effects, but depending on a patient population, can be really dramatic. So this is great. Less risk of overdose death, pain relief. But I've been ignoring something really important. What about addiction? Because dying of overdose death is not the only problem that comes from addiction. And those of us who've had family members who had addiction know this. And it's important that we don't just put a Band-Aid on a bullet hole and ignore this problem and say, like, oh, it's fine if 10% of people get addicted, at least they won't die, right? That's irresponsible. And so we need to talk about potential other strategies. We're not as far along here because it seems like addiction and pain relief happen through the same molecular pathway. But let's talk about a few possibilities. So where do these drugs act? Well, addiction, we believe, happens primarily sort of up here. It's in the reward system in the cortex, which is that big foldy part of your brain. And it seems like the opioids up there, acting up there, are what's causing us to aberrantly seek rewards. However, and again, like I mentioned earlier, what happens is that 3 times, the brakes are lifted on the reward system, the brain is flooded with that reward signal, oftentimes sort of simplified to dopamine, but fairly accurately represented as dopamine, and then you get high. And then where's pain relief coming from? So if you look in the brain stem, what you see is that there's neurons that have opioids on them that control breathing and pain. And so when opioids get into the brain stem, they can slow your breathing rate and in turn cause respiratory depression and potentially death, but also reducing pain. So potentially if we have these novel compounds that only reduce pain and don't cause the breathing rate, if we could get them to the brain stem but not the cortex, we might have a solution. There's one other place where opioids act, and I hinted at it earlier, and that's the spinal cord. So those small little neurons interacting in the spinal cord, the smaller part of your nervous system, they only regulate pain relief as far as we know, and also possibly itch. Some of these signals are important, but ideally, if there's no other problems, we could even just give our current opioids straight into the spinal cord. Okay, so why don't we do that? Well, who's seen a spinal needle, right? This is incredibly invasive. It has been done. There's methods that use this for pain relief in really severe situations, but there's a whole lot of other issues that can come from injecting into the spinal column. It's a high-risk procedure. So we see this as a potential solution, but probably not ideal. It's also important that not all pain comes from your body up. There's pain that happens due to what we call central circuits, so sort of from your brain stem up. And so treating just pain coming from the spinal cord might mean someone gets an injection and then nothing happens and they're still experiencing the pain. So we have some other possible targets I'll talk about really quickly. So the first is this other opioid receptor. This is my favorite. This is what I study. It's called the kappa opioid receptor. And it, like the opioid receptor I talked about earlier, relieves pain. But here's the really unfortunate part. It also makes you feel anxious and depressed. and it's actually critically involved in why stress over time feels terrible. But similar to the other opioid receptor, the pain relief molecular pathway is separate from the anxiety molecular pathway. So if we can design drugs that just activate pain relief without causing this feeling of awfulness, then possibly we might have a different type of opioid receptor that will definitely not make you addicted, because if for some reason it activated these other pathways, it would not make you feel good. But again, we would want to be sure that it only caused pain relief, because we don't want to give medication to people that increases their risk for depression. So a lot of ethical concerns to be careful as we do drug development in this area. And finally, some things you guys may have heard about. We're here in Seattle. There's opioid alternatives, and one highly popular one is cannabis. And it's still unclear what the mechanisms are for cannabis to relieve pain, but many people find it to be highly effective. You can get medical licenses for it. And it was also cannabinoid, which is a derivative that doesn't cause you to get high, was recently approved by the FDA for epilepsy. So it's our hope, some work is being done in our lab to try to figure out if we can get it, some basic experiments to show that it also helps with pain, and hopefully get that additional FDA approval for pain. It's been found through public health research that in counties that have legal marijuana, there's reduced overdose death. This is just a correlation, and we only have a few states where it's legal, but over time we're hoping to be able to see if there really is a mitigation where you have access to marijuana where there's less overdose death. And then finally, mindfulness is found to be really effective for many pain patients, and there's clinics at UW doing studies on mindfulness and pain. But again, patient sensitivity, if you've been receiving opioids, they've been helping you for years, you go into your doctor and they say, sorry, you're going to have to meditate. This isn't sensitive, and this isn't going to be what all patients want to hear. So this is a great technique, especially for people just presenting with pain, but it's only one of many options. Okay, so clearly from my talk, you can see that the goals of people in my area of research are to separate pain and addiction. We want to understand how to treat pain without risking addiction, and then also through these studies, we want to better understand how to treat addiction. So to treat pain, we can do things like develop better drugs, we can investigate alternate therapies like I just mentioned, and then finally, we can reduce prescribing bias, because it is not okay if in our society some people's pain is treated and others aren't. When it comes to addiction, again, changing prescribing practice is important, because we also don't want to overprescribe opioids for things like getting your wisdom teeth out, because that puts opioids in the hands of people who may not be as responsible with it, like teenagers. And then finally, reducing the availability of addictive opioids by at least trying to have some of these slightly less addictive options out there, and again, reducing prescribing. So thank you for your time, and I'll take questions.
Is there any insight into why some folks, they'll go to the dentist, they'll go to the doctor, and get their body done. Unbeknownst to them, they suddenly, for the first time in their life, feel normal. And they feel, gee, that's like it's sweet, like it's back in. What's going on with those folks, whereas the 80% of other folks seem to be, get rid of it?
That's a really interesting question. So some of it has to do with its actions on the receptors that interact with opioids, and some have to do with its interactions on other receptors. But it's generally thought that mild doses of opioids for people with depression can act as antidepressants. There's one drug called buprenorphine, which is used to help opioid addicts get off. That's actually being run in clinical trials as an antidepressant as well. It's just that these aren't often used because of the addiction risk. But people whose potential baseline neurotransmitter of reward is lower than baseline, they are effective antidepressants until addiction becomes a problem. Any other questions? Yeah.
So in your introduction, you talked a lot about U.S. statistics, and I was wondering, internationally, how do we compare to addiction rates and opioid use, and what other research is happening internationally?
So I don't know about every country. I don't know about necessarily rates overall, but I know that, for instance, I saw a study that was multiple Scandinavian countries, and they showed that of their addicts, over a period of 4 or 5 years, 20 to 30% were dying of overdose if they weren't enrolled in like treatment that gave them medical assisted treatment. So it's not like this is unique to the US. Like this is a problem in a lot of places. Yeah. Yeah.
Has there been any research on what makes that 10% become addicted different?
Yeah, so we do a ton of research on that at UW. We don't know for sure. Basically, everything we find is sort of chicken egg. So you find, oh, this is unique in this population, but like, oh, well, they've been drug taking. It does seem like there's a bunch of relationships between the part of our brain that processes dopamine signal, which is the reward signal, and some of that in the very few longitudinal studies where you look at sort of teenagers, do MRI scans before, and then like follow them long term, that there may be changes in how dopamine is processed. But that's just one of many things. It's thought that it's probably some kind of combination of small genetic influence, small epigenetic influence, and that all sort of mixes up into a soup of 10 to 30% of all drugs, 10 to 30% of people who use recreationally become addicted. Yeah. Thank you all so much.